This program is part of ANCOR's 2020 annual conference, one of many opportunities offered to ANCOR members throughout the year. ANCOR is the American network of community options and resources. Learn more about ANCOR and explore membership benefits and options at ANCOR.org. We hope you enjoy today's session.
Good afternoon, everyone. My name is Donna Martin, and I am ANCOR's Director for State Partnerships and Special Projects. And I am really excited to welcome you all to our virtual annual conference today. This session is active treatment during a pandemic. Before we begin, I'd like to thank our ANCOR sponsors and partners for helping us make this virtual conference possible. You can see them on your screen now, and remember to visit them during the virtual exhibit hours tomorrow and Thursday. You can register to participate at ANCOR.org by following the link to the virtual annual conference. We hope you can join us for some of that. Now for a few housekeeping reminders. There is closed captioning available for this session. To view the captions, select Closed Caption from your Zoom control, most likely along the bottom of your screen. We will be taking questions at the end of the formal presentation. So as you have questions, please remember to use the Q&A feature also within your Zoom controls along the bottom of your screen. We will address as many of them as possible at the end of the session. And for those we don't get to, we will get responses from the presenters, and that'll be included with the information that's sent out afterwards. And lastly, the video recording and the slides from this session will be made available after the event. So stay tuned for an announcement from ANCOR as to when that information is posted. Now I'd like to turn to introduce our presenters for today's session. We have Thibedeau, who has worked in human services for over 30 years. She has extensive experience in regulatory compliance, advocacy, and service delivery systems. In addition to serving as a consultant to ANCOR and the lead person for our ICF IDD community of practice, she is the executive director of an organization titled Independence Advocates of Maine, which provides both ICF IDD and HCBS services. And in addition to Catherine, we have our very own Than Johnson, retired CEO from CRSI of Ohio. Than has been involved in the field of disabilities for over 35 years. And CRSI, which he led for many of those years, is a multi-service nonprofit agency offering both ICF and HCBS services. Mr. Johnson served as a past president for both the OPRA and the ANCOR boards, and OPRA is a state provider association in Ohio, and Than spent over 20 years on both of those boards. He was also appointed to the Medicare Medicaid National Advisory Committee by President George W. Bush and served on the FCC Disability Advisory Committee, in addition to numerous policy and regulatory committees in the state of Ohio. Than was a governor appointee to the Clark State Community for 18 years and is a past president of his local Chamber of Commerce and YMCA boards of trustees. And just because he has so much free time, Than retains the Johnson family maple farm founded in 1805. So you can see we have two highly seasoned professionals in our service sector, and we are really excited to have them here today to talk about active treatment in the time of a pandemic. So with that, I'm happy to hand it to Catherine.
Donna, I'm just going to take a second here and share my screen. There you go. Okay. Well, great. Yeah, my name is Thibedeau, and I am serving as one of the two consultants for the ICF program for ANCOR, and I'm really excited to be here. This is kind of like a dream come true for me to have ICF employees and providers from all around the country together in one place, having the opportunity for us to learn from each other, and hopefully it's just the beginning of many more of these times to come. I'm going to just go ahead and jump into it. I have a little bit of leveling information here for you. Right, currently, there's 66,179 folks residing in ICFs around the country. And when you look at what the ICF population looks like around the country, you see that it's a population of people who tend to have higher medical needs, higher behavioral needs. And some statistics here are 62% of them are nonverbal and non-ambulatory, so they rely on somebody else to help them get around. If 40% have seizure disorders. Another factor, when you look at the ICF program and you look at the size of facilities around the country, 85% of them have 16 beds or less, with 74% of those having between 1 and 8 beds. So what that tells me is that the program itself is often run in areas where they're small settings and people with higher needs. So what does that mean as far as the pandemic goes and what we're facing right now? It's a population of people who fall into high risk and live in congregate care, okay? And there's a lot of decisions, we know that by now, there's a lot of decisions you need to make when you have those two situations that you're presented with. And for our program here, the ICF program, there's certain tools that we want to use when we're making those decisions. And the driver of the bus per se is the Center for Medicare and Medicaid Services. And from the group, the Quality Safety Oversight Group is the group that oversees the regulatory compliance, and that's what we're going to be talking about a lot today is our regulations, our requirements, and how we are going to continue to be able to comply with them. During this pandemic, they're putting out information in a couple of different ways. They're putting out information to state survey directors through policy and memo updates. They're putting out different toolkits people can use. And they're issuing blanket waivers. And as I go through my talk today, I'm going to reflect on, there's actually 5 current blanket waivers that apply to the ICF program that have already been issued, and there's several others that are being processed through their system. So on March 30th, there was probably the most substantial piece of guidance that was issued, and hopefully everybody here has seen that. And in that guidance, it really laid out what other tools should we be using in our decision-making process. And sort of the 2 main tools, other than CMS themselves, is the national CDC. And then the other is your state health authority, so your state public health system. And when you are moving through the process of this pandemic and how to make decisions, you're going to be wanting to go to those 2 entities and using them in sort of varying different ways depending on what your needs are. So your overarching guidance is the CDC. What to do in a particular situation within your building would be with what the state public health authority can help you with. And then I threw in sort of a 4th bucket that is important to not forget in this process, and that's your state agencies. And those look differently all around the country, but the licensing, the Medicaid, the developmental services agencies that will be providing you with guidance. So those are your external tools that you'll be using. And your internal tools will be your agency policies and procedures and your emergency plan. So I think we all remember Appendix Z. That was our friend from a couple of years ago when we were busily putting together our emergency plans. within our agencies and going through a process of having them surveyed and ultimately approved or corrected by our licensing bodies. And so in this time, right, you want to be sure you're pulling out your emergency plan, you're using it, and you're also modifying it as you go along. So I think, you know, Donna mentioned that I'm an executive director of an agency. I'm also the administrator of our ICF. And so, you know, I have a lot of day-to-day hands-on experience. Our emergency plan for a pandemic was about 1 to 2 pages long. And now our response plan is probably 40 to 50 pages long. So, you know, you're adding to your plan as you're going along. And as you're looking at your emergency plan, there's a couple of things that I call your friends. So looking for your friends within your emergency plan. There's the healthcare coalitions. There's a requirement by regulation that you belong as an ICF to a healthcare coalition, or you're linked with your healthcare coalition in some kind of way. And if you, for whatever reason, are not, this is really important that you link with them. They're not only going to be another resource for you, but that's certainly a potential of problem if you are not linked to your healthcare coalition from a regulatory compliance perspective. The other couple of places together that could be of help is your MOUs. And you know, the regulations strongly suggest you have an MOU with another ICF. It's not required. But those MOUs could be helpful to you if you were having a staffing situation where you're not able to staff your building. You can look to your partners in the community to help you with that. Alternate care sites. So there was a blanket waiver issued very early on that, well, for the purposes of this conversation, ICF services can be provided in other locations than your ICF building, and you can still bill for them. And where this may come in handy is with situations where you are isolating a person, a positive person, and you are wanting to do that off-site. So look to what you already have in place as far as that. The next two points on this relate to your continuity of operations plan that should be within your emergency plan. And on the March 30th memo, there's some referencing you back to those plans for a couple of different scenarios. And so looking to what your plan says now, what maybe would be helpful for your plan to say, and then adding that to your plan would be good things to do. And the first one of those is altering active treatment. So I know a lot of people have said, you know, what if we can't do active treatment? What if we need to alter what we do? How do we go about doing that? What if we don't have enough staff? And in your emergency plan, you could have that spelled out. So you could have, you know, in the circumstances when we do not have enough staff, we are just going to be doing health and safety level of care. And then that should sort of cover you for that scenario. And then the other piece of your continuity of operations is your essential functions. So when you, determining your essential functions is another thing, is sort of taking that, altering your active treatment a step further and looking at each of your positions within your organization or within your ICF and looking at what are the essential functions that need to happen for the residents to be safe and well cared for. So if you're looking at your direct care staff, you know, what are the non-negotiables basically? And then, and this is something that you don't want to be doing in the thick of it, right? If you want to be doing this when you have time beforehand and thinking through this process of, you know, what do we have to be doing at the bare minimum? What training would be needed if somebody else was going to do that? If you were bringing somebody in from the outside, if you were reallocating your staff in some way, and then what resources would they need? And as you sort of go through those things, you can be building this foundation to guide you should you have a staffing crisis. I'm going to move along now to active treatment specifically. So what is active treatment? And going back to what we all know active treatment to be is the formal and informal life experiences that the people who reside in ICFs have, and that it's continuous. It's something that goes on all the time. It's created in a way that aligns with and mirrors normal life. And when I was thinking about this presentation, I think this line stood out to me absolutely the most. Even in how we were preparing within our organization, what's normal life look like right now, and how is that telling us and guiding us in our decision making as an ICF. Active treatment is all about skill building, learning new things, and it has to be unique to the individual, right? So that's sort of, what is active treatment on a good day? And so what does that mean for us now, and how does that play into the pandemic we're having? Well, CMS has recognized that the active treatment will need to be modified, which is a good thing, right? So we all sort of know this. This is not something that should come as sort of a revelation or anything to us, but it is nice to see that they said that in writing. So they said that in the waivers that they issued last week. And they then waived one component of the active treatment, and that's the component, any parts of an individual's active treatment plan that would violate current state or federal requirements for social distancing, staying at home, only accessing essential services. So while that kind of gives a pass on the things that people are doing outside of the building or outside, and also things people are doing within the building that require people to be together, that sort of don't embody that social distancing and physical distancing requirement, they very clearly did not waive active treatment. So there was a very clear expectation that active treatment continues and that it is continuous. So then sort of what does that mean, and what now, right? So we know we're gonna have to be modifying what we're doing, but what are we gonna be doing now in place of or differently? And I suggest that we don't look too far, right? So we go back to that line of active treatment, that active treatment is to mirror or align with normal life, or what have you. So where are we in normal life, right? This is a time that kind of interestingly is very leveling across the country. We all are having to learn the same new skills. And so just don't think further than that. It's not necessary to think further than that for the people that we support in our ICF programs. So, for me, 4 weeks ago, I did not know what those words physical distancing meant. I didn't know how to physically distance. I didn't know how to keep in touch with my family when I couldn't see them every day. I had no idea what it felt like or what it was like to wear a face mask all day long at work. So those were all new skills that I had to learn. Or I'm still learning as we're moving along through this pandemic, and I'm sure that's the same for all of you. And that is what we need to be looking at within our buildings to ensure that we are providing the right active treatment at this time. And if you go back to those premises of active treatment and you sort of move forward through these new skills, so if you are now trying to figure out what modifications that I need to make to an individual's active treatment plan, I would look at these items first and say, do an assessment of where is their skill level, and then what can we do to create informal and formal ways to build skills in these areas. And then I know because we talk about it a lot, and I know it comes up. It's this, well, how do you teach someone these skills in 5 minutes, or the 2 days that we now need to learn these skills? And the quite you know, the honest answer is you're not. People are not going to be able to go from, hugging everybody every 5 minutes to maintaining that 6 feet of physical distancing. But this is our opportunity to be teaching and to be putting interventions in place so that they have a consistent and a forward-moving process to learn the skills. And looking to what you already know about the individuals that you're supporting. So what works for them? This is not time to be trying, some new interventions and new ways of doing things, but what is already working, and how do they learn best, or how are they best supported? What interventions work for them? And then taking sort of each one of these items and looking for skill building areas. But there's one that I want to just mention a little bit more on, and that is staying informed. And so this was in the March 30th memo from CMS. It was very, very clear that individuals with ICFs need to be informed of, educated on, included in the decision-making process and the learning process of the pandemic. So again, individualized, that would look very different for one person as to another person, but don't forget that piece of it. Don't forget the ways that you can be including the people you support in A, decision making, and in B, understanding what is going on around them. And there's lots of they linked up to some plain language pieces of information that you can use, and there's lots of information out there nowadays. So again, right, going back to that, mirroring and aligning with normal life, or what's going on for all of us. And all of us also now need different supports. And I don't know if there's a big differentiation between the new skills you need to learn or the different supports needed, but I needed 2 slides to put them on, and I want a different title, so that's what I did. But these things here are the items that we all are advised to do to be supported. And again, we don't need to be making up a different set of rules for people that reside in the ICF program. We may need to adapt it and adopt it and think about it a little differently, but it doesn't need to be a different set of rules. So we all need to be exercising our mind and our body. Exploring solo activities. So in this, there is some additional thinking that I think would need to be for people that live in congregate settings in ICFs. And that is to do some front load thinking on what solo activities each individual person enjoys doing, right? And then building a opportunity for that. So if you are in a situation where you're dealing with COVID positive individuals within your facility, the reality is that the residents that reside in those homes are going to be isolated. And when they're isolated, they're going to need something to do. So as a front-loading activity to go through the process of, if we were needing to alter what they do and have them be isolated in a room or isolated from each other, what activities does this particular individual like to do, and how can I explore additional ones that are like that, or get more supplies so we have them on hand, so that when and if you come into that, that situation, you're able to very easily deploy that. Thinking a little bit more about easy to disinfect activities. So a classic example for this might be an individual who plays cards and likes cards and has decks of cards, maybe purchasing them, some plastic cards that can be wiped down. people within ICFs live together and they share stuff, they share supplies, they share the craft, cupboard, and they share DVDs. And so looking for ways that you can have people have their own sets of stuff and there's less sort of sharing of everything. I think this is a great time to learn something new, right? Everybody and their brother is learning how to bake bread or grow a garden. But this too is, and again, informal, formal. They don't all have to be written goals and objectives, but these are other ways that people supported can fill their time, right? So adding some fun into your life. For me, right before this meeting, I was in another meeting, and I declared that I think we should be having Sweet Frog Monday. So in our area, the Sweet Frog frozen yogurt guy comes out, and different towns on different days will deliver us frozen yogurt. So Mondays he comes to our town of Orono, and we are going to have our Sweet Frog's a pretty popular thing around here for us. So that's going to bring us some fun, and it's going to sort of add to a routine. So Sweet Frog Monday, Taco Tuesday, or whatever works for you within your buildings and the people that you support. But having a routine and a schedule is a very important support for people, all of us, as we move through this pandemic. And we, as people who provide services in ICFs, are pretty familiar with the schedule component, right? So everybody needs to have an active treatment schedule. And don't forget your active treatment schedule and updating your active treatment schedule as you're moving along and making the modifications to your active treatment that you need to make. And I guess there's a couple different ways that you can approach this, right? So you can look at your active treatment schedules before you modify the active treatment, and that's going to show you where there's gaps, where people once had something to do and now they don't. Or you could do it after. You could say, these are the new skills that this individual needs to learn, and I'm going to put plans and informal and formal processes in place for them to learn those skills, and then I'm going to plug that into the active treatment schedule. Or it can be a combination of that. Where are there gaps? What can we do? Where can it be plugged in? But you do not want to forget your active treatment schedules. The last slide on this little active treatment portion of it, I'm going to talk about is documentation. So you document. Why do we need to document? Well, it tells people, our process of decision making, and in a highly regulated service like the ICF program is, documentation is going to be key come 18 months from now, 16 months from now, 2 years from now, when you are surveyed and you're being asked questions about what you did in the process. Another part of the recent waiver that was issued last week as regards to active treatment also made it clear that any modifications to individuals' plans need to be documented, and they need to be approved by their team. They did give the caveat that can be retroactive. So if a team cannot get together for some reason, then you can make those changes to the plan retroactively. So I envision 66,179 revised IPPs come the end of this pandemic. I think every individual, there's a process of decision-making, choice-making as we move through supporting people, and you want that to be documented in their plans. The other place where we want to document is in our emergency response plan. So if you, if you pulled out your emergency plan and it didn't, and what it had in it wasn't going to help you, and you did something new, you want to capture that in your emergency response plan. And then the last area is your progress notes, your daily docs. You know, different people have different ways of documenting on a day-to-day basis, but you want to be sure that you're capturing the changes, the decision-making, and what you're doing on a day-to-day basis with individuals as we are moving through this time. Oh. I like this slide. I think it's pretty cool. I couldn't find a place really good to put it in the presentation, so I stuck it in here. I moved it around so many times that it's always a surprise when I see it. So, so what are the surveyors up to right now, right? So that's interesting. On March 4th, surveyors were directed to move into infection control focused surveys and complaint response only surveys, and gee, they sure did that. So this slide shows you that if you go back to last year, in the ICF program specifically, there were around 850 surveys that were conducted each month. So some of those could have been complaint surveys, some could be standard surveys. Fast forward to April of 2020, and there were no standard surveys, and there were 56 complaint surveys. Interestingly, 28 of those were in Texas, and 28 of those were in California. The month's not over, so there may be more loaded up, but so surveyors are not in ICF buildings right now. And so that gives us time to make sure that we are doing what we need to be doing, A, and B, document how we're doing it. So this slide here, this next part is fun facts, right? So fun facts in the ICF program. What are the top 5 citations for 2018 and 2019, and why I think this kind of information interests me on a good day, but why I think this is helpful is there's a clear pattern of the areas where facilities are having some troubles, and that's with governing body, program implementation, nursing services, and med administration. You know, so you can see that they rise to the top when it comes to citations. They did in 2018, they did again in 2019, and so when you're sort of assessing your own building, your own facility, where you may find gap areas, it might help you to know what else is going on. The next, this is sort of a series of other regulatory thoughts that I had. That's what these slides are. These 5 regulations is the meat of infection control in the ICF federal regulations and requirements. So they are, there's not a lot there, but it's its own standard, so it's its own section. And I think it's important for people to know these regulations and be able to articulate your compliance with them. And I think that's a good sort of test of what you're doing, and pretty guaranteed that you'll be asked about that the next time a surveyor is in your building. There's 3 other regulations that CMS has waived portions of, or the entire regulation, and those are, that's regulation W136, and that's the opportunity to participate in social, religious, community group activities. So they're saying it's okay to not do those, but they're also saying that, and they've used this terminology a couple times, that, well, they're saying that this needs to be person-centered. So again, you know, making blanket across the board, no regard to what is going on around you for all of the people that you support is not the approach that is going to be successful. And this is an area, and I think with a lot of guidance, it is also this true, is that you need to listen to what's going on nationally, but really know what your requirements are locally. So what are the local emergency orders? And how can you support the people within your ICFs to comply with them? And the next regulation that they waived was this regulation that says direct care staff cannot do non-direct care duties. So they cannot do cleaning, they cannot do laundry, they cannot do dietary activities. Those need to be done by support staff. And they're waiving this and saying it's okay for direct care staff to do so. And I think that this comes into play when you have that scenario of, you know, how many people you may want to expose somebody to. You may want to be making some alterations there, and or if you are having some staffing difficulties. And then I kind of called this throwing a useless bone, but they waived, CMS waived the portions of W189. And that is the regulation that requires us to have a staff training programs. And then the portion they waived of that is any routine staff training programs that are unrelated to being able to respond to the emergency. And oh, by the way, it also, they also are not waiving any active treatment, behavioral training, health training, infection control things. So, you know, I thought long and hard of like, what training would that be? And I came up with maybe team building, supervisory training. We know that's a new requirement, that people get supervisory support. And so maybe that, I don't know. So as one of the many things ANCOR has done and is doing to support providers throughout the pandemic was to, we went through a process of looking at where else could we ask for waivers to regulations and it be meaningful for the ICF programs. And so this list here is a list of the other requests that we've made. Response is pending. It's a pretty slow process to get things through the waiver process from what I can tell, but I'll go down through these real quick. The first one is waiving the visitor and leave requirements. So there's several regulations that talk about people being able to have visitors and how they can have visitors and just asking those to be waived. Currently, the QIDP function cannot be delegated. That is a personal pet peeve of mine, but it's also problematic as we're dealing with the pandemic. You know, when we're trying to limit the number of people who individuals are exposed to, and I know there's lots of models around the country where the QIDP may serve that role in several homes, so they may not just be in one home. And without the ability to delegate that, to comply with the regs, you need to be moving from home to home, observing active treatment. So, so that's a request that could be delegated. Professional program staff must work directly with clients. So asked A for some clarity on that. So we asked CMS, you know, what does directly with clients mean? And then, you know, can you waive that during this time? And then requesting a waiver about preventative and preventative medicine, preventative healthcare, routine labs, and special studies. So we know that there's very specific regulations about when people get their physicals, and asking for that to be waived because, you know, physicals are not typically done through telehealth services, and there's limited mechanism to get them done. Asking them to waive active treatment when a building is in a health and safety situation. So as opposed to everybody who is encountering COVID positive individuals in their building having to ask for some type of waiver or depend on their emergency plan being written correctly, asking CMS to say, you know what, if you're in that situation, we're going to waive the program implementation regulation. recognizing the fact that the regulation requiring diets be prepared in accordance to the recommended dietary allowance is going to be a challenge in some places. So allowing people's flexibility with what they're providing for food and menu items. And then waiving the regulation requiring everybody to have their meals in the dining areas. So I think, I think on an individualized basis, people can use their emergency response plans to get around these. You can request an individual waiver, but the approach that ANCOR is taking is we're requesting blanket waivers for all ICFs in these areas. So this is Paige. So one of the challenges for me in doing a webinar through Zoom is that you can't click through to links. So I'm just going to tell you these were all made that you could click through to them. So I'm just going to tell you all about them. And then at the end of the document and embedded on a couple of pages on the slides are some links to different resources. And so there's a Google folder that I created, which has several materials that are referenced in this, and also has a Google Doc that lists out some resources for people when they're trying to develop different supports or maybe develop different skill building opportunities. And in general, I think, I'm kind of preaching to the choir with this. Sometimes it's hard to find resources that work well within the population of the people we support, and taking the generality that people that reside in ICFs tend to have more needs, and I know that's not the case in every ICF, but tend to have more limitations, maybe physically, than looked at resources that I thought would best fit into those categories. And I don't actually have a lot of time, so I'm not going to go around these, but I'll tell you a little bit. You see the eagle in the front, those are the eagles of Decorah, Iowa. That picture was a screenshot I took yesterday. And you can watch this mom eagle and her babies. The babies are all sleeping in their nest. And that is that's a live cam that you can watch, and it's very relaxing for us staff and for the people we support. And then I'm just going to talk about keeping busy. Keeping busy is a dementia-specific resource, though I liked them because they have a lot of products that are simpler in nature. So they have a bingo game, and instead of having 52 squares, it has 9 squares. Or they have lots of downloadable materials. They have word searches, and they have materials you can buy, and they have a list of apps. So if you're trying to do some new things with technology with people, they have a list of apps that I think are well adapted to the population of the people we support. And I guess I'm just going to quickly tell you about all of them. Sorry.
Catherine?
Yeah?
Excuse me, Catherine. We're at about 2:45.
Okay. All right. I'll move along then. So you can look at them through the Google Doc. And this is my last slide. This is our ICF here in Orono. I wanted to share with you. And now I'm going to turn it over to Than, and Than is going to Than has few slides that he's going to run through with you on the Medicaid and regulatory and things in more of a cool way.
Thank you, Catherine. Donna, can you hear me?
I can hear you, Than.
Thank you, Catherine. Again, I appreciate all of you today. When you think we have nearly 400 individuals signing on to this. And okay, I think I started did I start it? camera, hopefully. If not, it's okay. You don't need to see me.
Yep,
I want to do some generic presentations to you as far as what we've learned nationally, as far as how states are responding to this pandemic, particularly in the use of the K waiver and 1135. And Catherine went through some things, but as we look nationally, the two submission types of things that you can waive, K and 1135, included such things as we've already talked about that Catherine went on, such as our staffing crisis. And I'll come back to that staffing crisis too, because I think it's also something that the pandemic, if anything, might be helpful in illuminating the staffing crisis. The other is, as is on the mind of all Qs out there, is active treatment. I know someone like Steve Manley, who worked in our field for years and worked at the agency. Active treatment is what we live by, and having some relief on that in the idea that we are really striving for health and safety at this time. But we also need to take care of continuous treatment if at all possible. The other is not worrying about a survey coming in, the relief on surveys being scheduled during this particular time. Certainly, I would think that our different certification and licensing surveyors would understand that. There was also some relief on how, if someone in need in an emergency could become an emergency placement, and how we could seek some relief from that. Some various states asked for that. There also was something that I would be very happy to follow up on later, is the use of alternative resident settings. For those of you that have followed the TV with what's going on in New York and in many states where they had to do additional hospital beds, and they went into warehouses, places like that, on alternative settings. That's, I think, what they were mainly thinking about, but there may have been some states that looked at alternative ICF settings. And if so, please let ANCOR know on that, and I'd love to have that kind of discussion. There's relief on bed hold days. Sometimes we call them therapeutic leave days. And what we have found in that is that states have different days, amounts of days that they can do on bed hold, and some states have prior authorization for additional days, and some don't. I think that's something we could follow up on and having some consistency in the future. The use of telehealth, and I think that's a recent phenomenon that's coming on. And when we think about technology, certainly telehealth is something that would be very helpful after the pandemic, during and after the pandemic is finished with its course. Then we also look at some states looked at rate setting increases through the rate setting and also through retainer fees. I'm sorry to say that it would have been nice if all states asked for an increase in the rate for the ICF providers, given this time of staffing crisis, and certainly all the additional supplies that you needed to have, and then also retainer fees. The other is what we have in Ohio and maybe in other states, but on a weekly basis, we get what we call major unusual incident reports, which basically tracks, in Ohio specifically, the virus and its presence. And at this time, we're seeing about equal ICF presence of the virus of people that are positive, as we do in our supported living and waiver settings, except for our what we call our group home waiver, which has some. And then we also have one death that was in an ICF in one of the state centers at this time, and one in the families. So again, you're seeing this virus doesn't care what type of funding programmatic model you have. The other things to go over real quickly is the impact of provider viability and compliance. One of the things that needs to be considered by every state is, how do you keep your provider, particularly ICF facility-based services, how do you keep them alive? Because if not, then those consumers are in jeopardy, that they need that facility, they need those services, and what are they doing to assist in making sure that that provider is still viable and will be viable when we come out of this. It also is important that we not be bothered at this particular time with actual surveys being done, but be prepared for surveys that will be done in the future. Why some states submitted waivers and others did not, And part of it could be just a period of time, and the idea that states have to look at the financial considerations of submitting some of the waivers, particularly in rate setting, because the state has to come up with their state match of those federal funds. And that may be some of the considerations that are taking place that are delaying some submissions or have delayed some admissions. The other is it specifically an executive branch, in this case, the governor's submission, or is it something, particularly if it has a budget implication, that they have to have legislative approval? So those are some things that you could think about in your particular state if they have not requested either of the two waivers. And then the other is just how do stakeholders, particularly the ICF providers that are on this call, particularly those that do waiver services such as day services or residential, and the advocates and the parents. All of those are important and hopefully have some involvement in the discussion of waivers to certain regulations. The final thing, and it's a very, how do you say to someone in the middle of a pandemic that we have some things of silver linings, and I'll try to stress these, that they are positive in the fact that they actually are pointing out some things that we've been trying to point out, which just take, for instance, the staffing crisis. And Catherine and I have talked 2 to 3 times with the CMS ICF division, and they're saying, oh, yes, we know that you have a staffing crisis. Well, darn it, if you do know we have a staffing crisis, then why can't we react to that, particularly in our rate setting methodologies that are occurring or not occurring in certain states? So I think this is going to help us in validating the staffing crisis. When we think about states also that are looking at financial preparedness, I'd like, and Catherine, if you're still available, to speak about some states have already planned ahead for this before this crisis or pandemic ever happened. Maine is a prime example of that, and they have it in policy. Catherine, could you chime in?
Sure. So in Maine, we have a lot of good things going for us, and we have some struggles, but within the ICF program and a couple other service models, there is a rule that builds in a funding mechanism for an extraordinary circumstance. And it's called the Extraordinary Circumstance Allowance. And it is something that providers can activate if they're dealing with some unexpected situation that's occurred. And so I don't think when it was written, anybody ever thought that all, 5,800 ICF providers in the country would be having an extraordinary circumstance. But what it did allow very easily was for us to receive an adjusted rate to cover the costs of the pandemic within our ICF program. And that was about an average of about a 10% rate increase, and that we were going to have to cost settle at the end of the pandemic.
Thank you. And it's something that we'll certainly get further into as we go through this pandemic, but things that we can look forward to after we come out of it, that we can prepare for the next one, and hopefully that we never have. The last thing that I want to say is that this also gives us an opportunity to modernize parts of the ICF program and the use of assistive and remote technology. ANCOR has led the challenge of requesting through our state legislators, or excuse me, our national legislators to CMS, that there needs to be some place for technology in the ICF program, particularly when it comes to either using of cameras or of sensors, things of that kind, that is not there so we don't have to hire staff. It's there because we can't hire staff, to be very helpful without violating rights of individuals. So hopefully there is some positiveness that comes out of this. At this particular time, Donna, I'd like to leave this or open this up for questions that have been posted.
Sure thing. Thank you both for your information and your expertise. We have...
Donna, can I apologize. One other thing I learned from Catherine's presentation is that I will, leading into this, go back to a two-line introduction of who Than is. Okay, I took up too much time.
Our first question came at the top of Catherine's presentation, and the person is asking, what is the March 30th document that you were referring to, Catherine?
Sure. So on March 30th, CMS put out a state survey director's memo. And that memo was guidance specific to a couple of different service types, but one of them being in the ICF. And if you, so there's a couple of different ways you can get at it. But if you want to try to get to it before the slides come out, you can Google CMS current emergencies, and it's going to take you to a page that has all of the guidance. It has a lot of information, but if you scan down through, and I think it's under home health agencies or other provider types, you will see a link to this guidance.
And it may be on our ANCOR website. So
well, we could load it up there, Donna. That would be.
Yep. That's what I was going to suggest. We can do that. So you'll be able to find it on the ANCOR/COVID-19 pages.
Yeah, and also I did a sort of I think it was 16 pages, and I did abbreviate that down to a 2-pager if people are interested in that.
Okay. So our next question is, how are you developing new active treatment plans in the absence of PT and OT recommendations? This is particularly difficult with new residents who have not been assessed.
Mm-hmm. That's a very good question. So the first thing I would look to, and I'm not sure I'm not sure exactly if this is possible, if it's like physicals, but I would look to telehealth resources within your state. So there was a toolkit put out last week by CMS for Medicaid telehealth, and it was more towards states, but states should be opening up telehealth services. So I think that would be the first line of defense. The second line of defense may be having your nursing staff or your medical director make some recommendations or do some assessments in that way, and then document.
And Don, if I could add to that too, is going back to the thing about technology, is I think this would be a great example of where through telehealth or something that the PTOT can at least do some observation on and then make some recommendations virtually on things that would assist the individual.
It's a great suggestion, Dan. Thank you. Next question is with regard to the emergency preparedness plan, and the individual is asking if you are adding all of your COVID-19 pandemic response plans to the EPP, and they're saying that theirs is currently over 100 pages already, and can they choose what should be added to the main EPP?
Yeah, I can take that one. So there's a couple of things in there. You want to capture this as a real life event, so you do want to capture those 100 pages in your real life event documentation, and that certainly we won't have to do any drills this year because we're going through the real thing. But second, I would pick the portions that I would pick the portions of your response plan that address regulatory issues and make sure that those are in your emergency plan, or portions that you're going to reuse again, or you see are applicable to other types of emergencies.
All right. And I think we have time for one more question. And we have a person asking, how do providers gain additional funding during this time, including those who are supported by the waiver?
Well, that's $1 million question, isn't it? And I probably am not the best equipped person to answer it. But I know that and I can speak to the ICF program where we've been talking about and looking at that is if you don't, looking for the funding streams that are out there, if your state isn't going to take the initiative and provide a rate increase. So it's advocacy within your state level, advocacy on the national level, and I know ANCOR is doing a lot of that. Looking for loan opportunities, and Donna, do you want to take it?
I just wanted to add that, yes, absolutely. ANCOR and its advocacy on how the remaining funds in the currently active tranche of dollars, along with the $75 billion that was just re-upped, if you will, last Friday, our advocacy is very specifically been for all Medicaid providers. So that is inclusive of ICF, IDD services. But as Catherine said, we are working with Congress and with the Department of Health and Human Services to try to determine the best way, or if there is a way, to funnel those funds from Health and Human Services, Secretary Azar's office, to Medicaid providers directly. That's where we are currently finding roadblocks, but we are working quite aggressively on that.
Don, if I could also add, with ANCOR's advocacy at the federal level too, but we also have responsibilities at the state level to notify our Medicaid authorities, local authorities, that ICF is funded through Medicaid also, and that 6.5 FMAT increases can go through rate setting there as that mechanism can be used.
Yep. That's another great point of advocacy, is working with your Medicaid office on access to funds generated through the FMAP bump. Absolutely. Well, folks, we are over our time. I want to thank again Catherine Thibedeau and Than Johnson. They did a remarkable job. We've gotten some great questions that are still outstanding that we will get to offline. And we've gotten some great comments in the Q&A for the job you both have done. I want to thank Anthony Trujillo, who has been our closed captioner. And again, a special thank you to all of our ANCOR sponsors and partners. Thank you, everyone.